lung cancer has shown a decrease in incidence and mortality in recent decades. However, it remains one of the cancers with the highest incidence and still ranks first in cancer-related deaths in the United States. Advancements like molecular interpretation of lung cancer has substantially changed the classification and the treatment of these tumors, becoming an essential component of the diagnosis and the therapy decisions. Throughout the recognition of novel biomarkers such as epidermal growth factor receptor mutations and anaplastic lymphoma kinase translocations, it has become possible to identify the subset of patients who will benefit from targeted molecular therapies. Thank you for joining us.
Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Hello, I am Dr. Manmeet Ahluwalia, Chief Scientific Officer, Chief of Medical Oncology, Deputy Director, and the Fernandez Family Endowed Chair in Cancer Research with the Baptist Health Miami Cancer Institute. And joining us for our discussion is Dr. Upal Basu Roy, Executive Director of LUNGevity Research. Dr. Roy spearheads LUNGevity's translational research programs and patient-focused research center.
Thanks for having me, Manmeet.
We are so excited you are sharing this afternoon with us. The importance of lung cancer screenings and who should consider them. Can you enlighten us about that, Upal?
Absolutely. So lung cancer screening is a life-saving tool that's available for people at high risk of developing lung cancer. And I think there are three questions to keep in mind when someone's considering lung cancer screening for their patients. The first question is, how old is the person? Lung cancer screening is available for people between the ages of 50 and 80. The second question is, does the person have any history of tobacco exposure and for how long? So lung cancer screening is typically available for patients who have at least a 20-pack year of tobacco exposure, and that's 20-pack years of cigarette smoking. And the final question and the third question is, for how long has the person smoked? And right now, lung cancer screening is available to someone who is either a current tobacco user or someone who's quit within the past 15 years.
As you know, this lung cancer screening was actually broadened in 2021. How have you, in your work throughout the country, seen an uptake in terms of lung cancer screening?
Manmeet, I wish I could say that we've seen an uptake in lung cancer screening, but even as we speak, despite the USPSTF changing the lung cancer screening guidelines in 2021. As we speak today, the current uptake for lung cancer screening is about 4.5% nationally. And in the state of Florida, it's even lower, with about 2.4% of people who are eligible for lung cancer screening actually receiving screening.
Yeah, so I think you bring up a very eloquent point that we all can do much better.
Absolutely.
Even the states like Massachusetts, which are on the top of the podium, they're only doing around 16% or so. So we are all have a lot of opportunity to serve our patients because lung cancer screening actually saves lives.
Absolutely.
And one of the other things that we've been very excited at Baptist Health South Florida in our partnership with LUNGevity is the real potential of our partnership of establishing the first Hispanic lung cancer screening program. Because as you know, the minorities tend to screen at a lower rate compared to the white Caucasian population. And what we have found out, at least when we looked at our data here in South Florida, in Miami area, where 70% of our patient population is actually Hispanic, that those screening rates are only around 2%. And I know you've also done some work related to African Americans in other places. Do you want to share with the audience the programs that you've done at one or two other institutions in Northeast? And then talk a little bit about our partnership.
So let me tell you a little bit about a partnership specific to New York City in the Bronx, particularly. And again, the Bronx is a very diverse community, and the African-American community within the Bronx is particularly minoritized, and only 1 to 2% of the African-American community receives lung cancer screening. So again, through a partnership with the Montefiore Einstein Cancer Center in the Bronx, we made concerted efforts through community engagement to ensure that first, community members are aware about lung cancer screening. And secondly, they can actually access lung cancer screening, which then brings me to the partnership with the Miami Cancer Institute. And again, this is very near and dear to our heart because, again, Manmeet, through your point, you mentioned that members of the Hispanic Latinx community do not receive lung cancer screening. So we as a patient group, we were very interested through this partnership to first figure out why. And secondly, using that information, how can we improve lung cancer screening and care linkage, which is essentially the focus of our partnership. And it's been really great working with the MCI team to further your efforts in bringing this life-saving technology to the Hispanic Latinx community in South Florida. And I think to your point about underscreening, I think people often forget that lung cancer, the Hispanic Latinx community is often linguistically isolated and they don't access healthcare in English like most of the US population. And therefore, I think a pivotal piece of our partnership has been really ensuring that we have screening education materials, awareness campaigns in Spanish so that it really meets the needs of the community.
No, I think you bring up a very important point, just as I had stated earlier, and I would like to reiterate. 70% of patients in the Miami-Dade County are Hispanic in origin. That's the patient population actually Baptist Health South Florida serves in this 4-county area. And almost 18 to 20% of them are linguistically isolated. So we've truly enjoyed our partnership with LUNGevity, where we actually formed or formulated the first Hispanic targeted lung cancer screening program, and kudos to you and your group for providing the educational material to support our patients. And I'm very excited to share that our screening numbers have gone up tremendously as a result of our partnerships in the last 3 to 4 years. We used to be less than 2,000 patients that were screened for lung cancer screening. And this year we are hoping that we'll reach around 3,800 to 4,000 patients.
That's fantastic, Manmeet, to see that the program's actually having an impact.
Yeah, definitely. The sheer numbers just speak to that because, as they say, numbers don't lie.
Absolutely.
But what is interesting, though, is despite us serving 65 to 70% Hispanic patients, when we looked at our data, still in lung cancer screening, only 40 to 42% of our patients are Hispanics. And it's pretty much equally divided between males and females. So I still think there is work still to be done.
Sure, absolutely.
Which lends us to a very interesting part that you and I have talked about, and we are trying to get our primary care physicians involved, which is to work on grants to really get more partnership with the primary cares. So can you share with, since a large part of audience of this podcast are primary care physicians, some of the things we can do in partnership with them?
Absolutely. So anyone who is a primary care provider and listening in, thank you for everything that you're doing for cancer preventative screening, because you are really the gatekeepers to ensure that our patients have access to all types of cancer preventative cancer screening. And one of the things that we've discussed doing, now the first partnership was very focused on the community. Now the second partnership is going to be focused on ensuring that primary care providers, all of you, have the necessary tools and the information to engage your patients with lung cancer screening programs in the community in the South Miami, in the Miami-Dade County area.
Yeah, thank you so much. And again, I think once again, I want to reiterate our huge gratitude for you and your group to partner with us, because I think with the resources we were able to get of several grants that we have together, we've been able to get patient navigators who are critical, right? Because one of the challenges in the minority patient population is there's sometimes issues of education, awareness, but also trust. So we are trying to specifically incorporate people who look like the patients that we serve, who are part of the community, who can actually go into the community, go to the faith-based organizations, organize awareness campaigns with several Baptist Health South Florida events that we are doing for people at large.
And Manmeet, thanks for bringing up the role of patient navigators. I think we cannot underestimate how important patient navigators are to connect the community to the necessary care that they require. And we really appreciate this partnership because of the fact that we really leverage the assets of the two organizations to create this program.
And so for our primary care physicians out there and our general audience, I just want to make some points which really highlights why is lung cancer screening so essential to saving lives. Most of our patients, unfortunately still, majority of our patients are diagnosed when they have locally advanced disease or metastatic disease. And typically, the outcomes of these patients is only around 20 to 25% survival at 5 years. This contrasts to 60 to 65% survival at 5 years in patients who are diagnosed with early stage disease, where we can actually surgically remove the disease. And then now we have had a number of trials which have actually showcased the importance of targeted therapy and immunotherapy. So, Upal, I know you've been involved with LUNGevity for over 10 years now. I've been a medical oncologist in training and then in practice for close to 20 years. And I've really seen the field of lung cancer being transformed. Can you talk to our audience about the importance of biomarker testing and targeted therapies?
Absolutely, Manmeet. When I started at LUNGevity, we had just one targeted therapy approved for lung cancer for one type of mutation, the EGFR mutation. And as we speak right now, we have targeted therapies for 9 different molecular biomarkers, and these are targetable mutations. And to your point, Manmeet, why is molecular testing important? Molecular testing is incredibly important because that's the only way to identify if the tumor has a targetable biomarker and then ensuring that the patient gets matched to the right treatment at the right time. So 10 years ago when I started, the need for molecular testing did not exist. But now molecular testing has become incredibly important, and for both metastatic disease as well as early stage non-small cell lung cancer.
Yeah, so again, I would want to particularly focus on EGFR alterations because 70% of our patients are Hispanic. And what we do know is that EGFR mutant lung cancer is more prevalent in Hispanic patients compared to the white Caucasian. In white Caucasian patients, it's only around 10 to 15%.
Sure.
But in Hispanic patients, it's like 40 to 50%. So can you share this journey that you've seen of this plethora of drugs now approved for EGFR mutant lung cancer?
And again, doing a little bit of a history lesson here. When I started my role at LUNGevity, all of the drugs for EGFR positive lung cancer were approved for metastatic disease, so disease that's spread typically to the other lung or to the lymph nodes or to other parts of the body. But 2 years ago, there was this pivotal clinical trial called the ADAURA clinical trial that read out, and that suggested that if you use one of these EGFR drugs, osimertinib, also known as Tagrisso, for early stage lung cancer and giving it to patients after they've had surgery as an adjuvant treatment, then it dramatically increases the cure rates. And this was something that's unheard of. That was unheard of 5 years ago. But now we have these drugs for EGFR positive lung cancer available for patients diagnosed with early stage lung cancer. And that's why I mentioned that, again, testing for these biomarkers for early stage in early stage disease is critically important. So we can actually match patients to EGFR drugs if their tumors have the mutation.
Yeah, thank you so much for highlighting the ADAURA trial. I think it was a transformative study.
Absolutely.
Because it clearly showcased that if you did not give these patients anything, a placebo, their time to recurrence was around 28 months. And if you gave them the drug, then it was over 60 months. So, and the hazard ratio was 0.27. So our physicians know that if you are improving your chances of not having a cancer come back, decreasing it by 4 times, that's pretty impressive. So I think that's a great study. Also, I think similar work has been shown in, as you know, with alectinib in the ELENA trial in ALK translocated lung cancer, which is around 5% of all the lung cancers we see, where actually the data is not even mature to tell us how soon the tumor will come back, but the hazard ratios are again 0.25 or in that ballpark. That means it is 4 times less likely that the tumor will come back if these patients are getting these drugs. On the metastatic setting as well, where, as you know, I treat patients with brain metastases from lung cancer, and we have seen a transformative change. And here, actually, I'm going to use the example of ALK translocation lung cancer, because when I started treating these patients close to 20 years back, someone who had ALK translocation lung cancer with brain mets, they survived only around 9 months. It was very aggressive form of lung cancer. And now with these new drugs like alectinib, the outcomes of these patients is more than 5 years. In fact, the latest data that was presented, the CROWN study update at ASCO this year showed that for 5 years, actually the tumor is not even growing, which is just mind-boggling. And it gives me goosebumps just looking at how much difference we are making in the lives of our patients because of the advances in science.
And you bring up a very good point, Manmeet, about 5 year survivors. 10 years ago, we did not have patients living for more than 1 to 2 years, but now you have patients who are living for more than 5 years. So we are in this era of transformation, of innovation, of really sort of changing survival for our community.
So one of the take-home points in summary for this section of our talk is genomic testing is
Absolutely.
essential. We are living in an era of precision oncology, precision medicine, where every patient is different. They need to know that. And that's the message for physicians and community at large, that if you have a patient with lung cancer, they need to have molecular
Absolutely.
testing being done. At Miami Cancer Institute, we actually use Caris Life Sciences, which has a whole exome as well as a transcriptome, because we believe having a comprehensive testing effort. Because if you don't test for it, you won't see it. And if you don't know, then you won't treat your patients with these targeted therapies. And another take-home point is these EGFR lung cancer patients, even those who have metastatic disease, that means their lung cancer has spread beyond lung to other parts of the body. If you treat those patients with chemotherapy, your outcomes are like 12 months. But if you start using targeted therapies like osimertinib, the outcomes are 38 to 39 months. So it's almost 3 times more. And patients can tolerate these targeted therapies much better than chemotherapies, because with chemotherapies, you can only give it to a certain period of time before their bone marrow starts getting affected. So I think that has been great. And obviously, we had a couple of very exciting trials reporting in the last year or two. The Mariposa study, for example, now is now looking at combinatorial approaches. So as you know, Mariposa 1 really showcased that amivantamab along with lazertinib did even better than osimertinib, showing a 7-month progression-free survival benefit on top of what osimertinib was doing. And when our patients with osimertinib get progression, unfortunately, we know amivantamab and chemotherapy is almost twice as effective than chemotherapies. So can you speak about some of the other efforts in other molecular types of tumors that you've seen and what LUNGevity may be supporting?
I'm actually very thrilled. I'm going to go back to your point about the Mariposa trial and having options for people with EGFR positive lung cancer. They have options. Now you have osimertinib as one treatment option. You have osimertinib plus chemotherapy as another treatment option. And then you have amivantamab and lazertinib as another treatment option. So 3 treatment options for people living with metastatic EGFR positive lung cancer as their first treatment option. This is unheard of, Manmeet. We did not have this in the past. And I think we are seeing similar trends in other types of molecularly targeted lung cancer. For example, you talked about ALK-positive lung cancer. And I want to go back to one point you made, which I really appreciate, doing whole exome sequencing and transcriptomic sequencing, because it's really important to sequence both the DNA and the RNA from the tumor, because some of these molecular biomarkers, sometimes they show up in the DNA, sometimes in the RNA. And it's not just about matching patients to an ALK drug or an EGFR drug or a BRAF drug. It's also making sure that they don't get the wrong drug. And chemotherapy, I wouldn't say is the wrong drug, but very often patients whose tumors have these molecular alterations, they do not respond well to immunotherapy. In fact, immunotherapy is almost contraindicated for these patients. So molecular testing is not just about matching the right patient to the right drug. It's almost about ensuring that the wrong drug is also not given to the patient. And we are seeing that more and more for all of the different targeted therapies that we have now at our disposal.
And again, you just alluded to one of the other transformative changes in outcomes of our patients in lung cancer has been due to immunotherapy.
Absolutely.
Do you want to enlighten our audience about the role of immunotherapy in early stage disease as well as metastatic diseases?
Absolutely. So immunotherapy, again, like targeted therapies, is available both for metastatic lung cancer without any targetable or targetable mutations. And it's also available for early stage patients before or after surgery, and sometimes given both before as well as after surgery. And I want to go back to the original goal of the conversation, Manmeet, which is about the role and importance of lung cancer screening. As we speak, our technology to offer surgery has drastically improved and continues to improve. And we talked a lot about some of these new innovative treatments in early stage disease, targeted therapies, immunotherapies. Now we are combining surgery with targeted therapies or immunotherapies, and the chances of a cure are higher than never before. So the time is ripe to offer lung cancer screening to our community.
Yeah, that's a very eloquent point, Upal. And just for our audience out there, as Dr. Basu had alluded to, if you use immunotherapy either before and after, what we have found out is that outcomes of these patients are improved tremendously. In fact, sometimes when we do chemo before surgery and then we take patients to surgery after that, that approach is called neoadjuvant therapy. And if you do it only with chemotherapy, the pathologic complete response, that means in how many patients the tumor goes away completely, is only around 4 to 5% with chemotherapy. But we are seeing that numbers now being 18 to 20% if we are using immunotherapy either by itself or in combination with chemotherapy. So that's like 4 times greater chance of having a complete pathological remission or response on therapy. And then, as you mentioned, we even augment it typically with additional maintenance immunotherapy for a year or two. And I think so overall, what we're really doing is we are giving people a second chance.
Absolutely.
And that's why we come back to the point that lung cancer is so critical, because we want to, in the next 5 to 10 years, and that's the effort that we are in partnership with LUNGevity are really going for cures. We are going to move these patients from stage 4 disease to early stage disease, because that's where the cures are really possible. Now, obviously, we've done much better in how we take care of our patients with metastatic disease, and immunotherapy has been quite transformative in that as well. Do you want to talk about some of the drugs or some of the treatments that are available and how much better are these patients doing?
Absolutely. And again, going back to one of the points about molecular testing, patients who are diagnosed with squamous cell non-small cell lung cancer or adenocarcinoma, again, which is a type of non-small cell lung cancer, which does not have any molecular alterations, immunotherapy has been absolutely revolutionary. And immunotherapy is given to patients based on how much their tumor makes a protein called PD-L1. And now we have 6 different immunotherapy combinations available for patients. And each of these are highly effective. And patients who respond to these drugs have a really, really good response rates. And again, going back to that point about 5-year survivors, Manmeet, we have 5-year survivors, patients who have no evidence of disease called NED after immunotherapy. And that has never been seen in lung cancer before.
No, absolutely. Just to drive home the point, when I started, which was almost like 20 years back as a medical oncology fellow, the outcomes of stage 4 lung cancer was less than 5% at 5 years. And now with all the transformative changes that has come because of testing, targeted therapies, immunotherapies, 20 to 25% of our patients, at least at academic centers, are surviving at 5 years. And I feel in the next 5 years, that number will be improved even more. But coming back, I think one of the other importance of our effort in terms of lung cancer screening is because it deals well with the Biden moonshot prerogative, which is to decrease the cancer mortality by 50% in the next 25 years. And I think critical for that is screenings, biomarker testing, and making sure that the minorities are getting screenings and treatments on clinical trials. So in the next couple of minutes, can you talk about some of the efforts that are being done in terms of ensuring that minorities are not only getting screened or getting appropriate treatment on clinical trials, and what LUNGevity is doing to further enhance that effort?
And I'll start off by saying that as a patient group, our goal is to make sure that every patient, or I would say every high-risk individual and every patient, gets the best care possible, no matter who they are and where they live. And the reality is, this is a very complex and systemic issue, Manmeet. So we as a patient group, as a patient advocacy group, we've taken a multi-pronged approach. And we are doing local level efforts, such as our partnership with the Miami Cancer Institute to bring lung cancer screening to the Hispanic Latinx community in Miami. Then we are doing state level efforts. For example, we have a campaign very, very focused on in the minority community, looking at biomarker testing, which we talked about, and in Georgia, in the Atlanta area. So that's a state level effort. And then, of course, we also believe that at the end of the day, policy level change is the biggest way to make an impact. And that is the reason why LUNGevity is very focused on driving policy level change that removes barriers to innovation and removes barriers to access. And as an example, and we'll again use lung cancer screening, we've been champions for ensuring that lung cancer screening is covered by all private as well as public insurance, all public and private payers in the United States, and we are moving in that direction. A couple of years ago, the state of Florida the Medicaid population was not covered by lung cancer. Lung cancer screening was not covered in the state of Florida, but that has changed. So we are seeing some of our efforts leading to what we want to see.
So thank you so much for your groundbreaking work in the field of lung cancer. So really want to thank you and your organization for, making sure that we can cure more people. What I would also want to summarize at Miami Cancer Institute, we certainly believe in that. We are addressing these gaps in disparities of care for minority patient populations. So we believe in a clinical trial for anyone who walks through our doors in Miami Cancer Institute, as well as with a particular focus on increasing minority enrollment to clinical trials, because I think that is going to be the key if we can really further the work of the Cancer Moonshot program to really serve the community and decrease the mortality by 50% over the next 25 years. So with that, I would really want to thank Upal for making the trip to Miami to visit us.
It's been a pleasure. Thank you for having me, Manmeet.
And for your partnership. And I look forward to working with you and your organization for next several decades.
Thank you very much.
Recent innovation in the treatment of lung cancer has come with improved understanding of molecular profiles as they relate to which patients will benefit from which kind of therapy. For some patients who have oncogenic-driven tumors, we are now using targeted therapies, as we saw in our discussion. For patients who do not have those alterations, immunotherapy has truly transformed the outcomes of these patients, and we have a number of our patients who are living 5 years and beyond. We are encouraging patients to learn more about their lung health by offering special pricing on lung screenings through the month of November. Patients without health insurance or whose insurance does not cover the test can receive a lung cancer screening for $35. A prescription is required. This Lung Cancer Awareness Month, stay on top of your lung health by visiting baptisthealth.net/lung screening or call 833-596-2473.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.